What I was discussing, that there are four blocks that is commonly performed at the thoracic area for the chronic pain. One is the thoracic facet joint block. Though the problems with the thoracic facet joint is comparatively rare, and the thoracic facet joint, the pain incidence is comparatively rare, so the block required is less common than the other areas. Number two, commonly performed with the myofascial pain that we are not discussing today, but definitely there are multiple muscles. So you have to, there could be possibility of the trigger points, and in a number of chronic pain patients, we found that the myofascial trigger points are present in the thoracic spine, for which we have to go for the trigger point injection. The third one is the intercostal nerve block, which can be given for the post-herpetic neuralgia, for the intercostal neuralgia, or sometimes for the post-thoracotomy scar neuralgia. So in those conditions, you can go for a block of the intracostal nerves. Then paravertebral block, which is mostly an acute plane block, which is given in case of chest injuries and other things. In chronic pain, the use of paravertebral block is limited, though we'll be discussing the paravertebral block as well. And the last but not the least is the erectospinal block, the newest block. In fact, when we started our pain career, that time this block does not exist at all. It is invented much later, and it is an alternative to the paravertebral block because at the paravertebral space, it is really close to the different important structures like pleura. It is important to the nerve roots. That is why here the erector spinal block came as an alternative, which can actually effectively block this pain from those nerves. Okay, let's start with first one, that is the thoracic facet. Now, what are the difference of the thoracic facet with the other areas? The most important one is the angulation. Remember, unlike in other areas, thoracic facet is much vertical, and they are much deep seated compared to the lumbar or the cervical areas. So here accessing this joint is much more difficult than other areas. Number two difference with the thoracic facet joint along with from the other joints is that for most of the lumbar and cervical area, there is a fixed position over the bone on which we can go for the medial branch block. But that is not the same in case of thoracic area, because what happens in the thoracic area, the medial branches vary in their positions, usually at the first initial four, that is T1 to T4, and also in case of T10, they are situated mostly in the upper and outer corner of the transverse process. In T11 and T12, they remains like a lumbar, that is close to the junction of the superior articular process and the transverse process. But the problem happens in case of T5 to T9. At this area, this medial branch, which in all other areas are situated at the level of the transverse process, here they are situated slightly above the transverse process in the intertransverse area at the same level of the transverse process and the rib. So in those cases, we have to take the help of stimulation to find out the exact location of the medial branches. Now coming to a little bit of the epidemiology, thoracic facet, the pain affects 13 to 15% of the population. It is less common than the cervical or lumbar pain, but impacts the daily life significantly. And there is significant injection risk is the pneumothorax due to the poor visualization under fluoroscopy. Conservative treatment sometimes can be insufficient, and ultrasound provides real-time view of the pleura, vessels, and the nerves. So that is the advantage of the ultrasound. And what are the indications for the facet joint block? Mainly chronic mid-back pain from the facet pathology. Now, facet is formed by the superior and the inferior articular processes, which is 60-degree axial and 20-degree frontal, and it is the synovial joint with the cartilage and capsule, and pain may refer to the trunk or the leaf cage. Ultrasound-guided thoracic facet joint intra-articular injection was first described by the Suttle et al. In the cadaveric model. Now coming to the tonoanatomy. Usually, the patient should be placed in the prone position, or it is possible to in a sitting position as well. But when you are doing under sitting position, be careful about the esophageal attacks because that sometimes can be a little bit difficult to handle in some patients. So, except if the patient is aged, usually avoid the sitting posture. In young patient, that can be performed. Usually, patient is we keep prone use 1 to 7 megahertz curved array probe. Remember, in very lean and thin patients, sometimes it is possible to see the joint with the linear probe, but most of the patients require a curvilinear probe. Now, you have to find out all the structures starting from the central to gradually over the lamina and then go over the try to find out the IAP and the SAP. That means the inferior articular process and the superior articular process. And then in between the inferior articular process and superior articular process, try to figure out the joint. Facet visualized between two hyperechoic lines and looking like the same. And here the view we use is the paramedian sagittal view, and ultrasound is sometimes superior to the fluoroscopy in case of thoracic facet joints. Okay, because in fluoroscopy going through the angle sometimes becomes more difficult, whereas in ultrasound if we go in a much angular plane, the needle visualization actually improves. Now, first we have to locate from the T12 rib, so that from below, locate the T12 rib, go medially, and from there start on counting the level. And once you got to your desired level, then try to find out the area in between superior and the inferior articular process, and then put the needle in inclined longitudinal view, and 1 to 2 ml of local anesthetic will be given close to the joint. Remember, if you are doing a pure diagnostic block, your needle volume should be within 0.5 ml. But if you are doing a diagnostic and therapeutic block, in that case, you have to inject a little more volume. Advantage of the ultrasound. First of all, real-time visualization improves safety. You are not going to the pleura. That is easy to make ensure. To reduce the risk of pneumothorax, then accurate needle placement, no radiation exposure, and the ideal for the outpatient department. And coming to the medial branch block, this is one of the landmark cadaveric studies that has been shown the position of the medial branches at the different levels of the thoracic spine. So as I told, from this area T1 onwards, T1, T2, T3, T4, they are limiting to the upper and outer corner of the transverse process. So in that case, we need to find out the transverse process level and the most outer part, and then we have to move at the upper outer corner of it. Whereas from T5 to T9, it becomes more difficult where it is situated actually in between two transverse processes. So in that case, you have to first hit the upper border of the lower transverse process, and then you have to move up and then go for the stimulation, and with stimulation try to find out where your location is. Once you got the position of the median branch, then you can go for the local anesthetic injection followed by the radio frequency ablation, or if you are doing a only diagnostic block, you can inject the local anesthetic here. And from the T10 onwards, T10 again it comes towards the upper outer corner of the transverse process, and from T11 and T12, so it is mostly at the junction of the superior articular process and the transverse process. So it moves medially. There are a number of studies which has been shown the clinical application of the ultrasound guided thoracic medial branch block and thoracic nerve radiofrequency ablation with good results. And also there are a few more studies which is shown here. They have also concluded the positive effect of the ultrasound guided medial branch procedures. So here we can see the transverse process, and this is the cephalad side, this is the caudate side. Here in between two transverse processes, we are going to the upper outer corner of the transverse process, and we are putting in an angulated manner so that our needle can go to the upper part. The outer part you need to confirm by moving the probe slightly to the lateral and medial, so that you are just seeing the transverse process from the rib. The technique will be shown just now, and once you are confirmed that it is the upper outer corner, you just put the needle at the corner and then give 0.5 ml of the local anesthetic. That is the median branch block under the ultrasound guidance. Coming to the limitations. First of all, ultrasound requires an additional training, additional to fluoroscopy, and initially finding the structure sometimes can be a little bit difficult. Sometimes acoustic shadowing could be obscuring the bone and the deeper structures. That happens every time, but here as the Transverse process is the most lateral and the most, not the most lateral, but it is the most superficial and lateral structure compared to the deep. It can be, once you are experienced enough, you will be able to easily differentiate this structure. Inability to confirm the intravascular injection without the contrast. That problem is there with the ultrasound. It is here also and it will remain. So fluoroscopic confirmation in some cases may be necessary, especially if you are suspecting that you are within a vessel. Go inject the dye and check, and then will be confirmed. So in here sometimes we do a dual technique where we use the fluoroscopy and ultrasound both together. Now coming to the future directions. First of all, we require more of the comparative studies with the ultrasound and fluoroscopic guided outcomes. Safety comparison, these studies are lacking. Then further exploration of the accuracy and outcomes using the ultrasound probe alone and with the continuous RFA probe placement, and aim is to extend to the safe radiation-free technique for the thoracic pain intervention. So this requires a little bit of further study, definitely. Then we can be sure that ultrasound is better than fluoroscopy. We will be able to tell at this area. But still now, we usually prefer the hybrid technique so that we can take the best of the both the worlds and we can perform it accordingly. Okay. So it is not difficult. It will be demonstrated. But before the demonstration, let us discuss another block, that is the intracostal nerve block. Okay. So first I will be discussing two blocks, intracostal block and one I have already described. Then we will be moving towards the two other blocks, that is the paravertebral block and the erector spinal plane block. Now intracostal nerve, this is a division from the anterior division. Remember, the intracostal nerve block is a quite old block. It is originally described first in 1907 and its use started in mostly from the 1940 and definitely usually for the initial thoracic injuries. Then it is extended for the chronic pain conditions as well. Now, if you look at the thoracic nerves, they are dividing into paired ramines. They are mainly the gray and white ramine, from the nerve 1, the sympathetic flow is going to the sympathetic chain, and from the sympathetic chain, the postganglionic fibers, they are coming back to the nerve roots. Whereas there are two more ramas. One is the dorsal ramus, one is the ventral ramus. We know dorsal ramus going to the posterior side. They are supplying the skin and muscles in the paravertebral region. Whereas the ventral ramus, they mainly responsible for the intracostal nerve function. Just one second. So So it is dividing into dorsal ramus and ventral ramus, whereas the ventral ramus is mainly responsible for the intracostal nerve function. So from this area, these are the ramuses. Here they are forming the spinal nerves, and here this is the dorsal ramus. Dorsal ramus is giving three branches: lateral, intermediate, and medial. The medial branch supplying the facet joint and the multifidus. Now coming to the distribution of the nerve fibers. T1, T2, along with the thoracic area, it supplies portion of the upper extremity as well. T3 to T6 supplying mainly the thoracic region. T7 and T11 innervate in the lower thorax and abdomen. Umbilical portion is supplied by the T10, whereas the T2 innervates the abdominal wall and the skin in front part of the gluteal region. So depending on the area, we have to put our block. Now coming to the indications, there are a number of indications for which this block is done for the acute condition, like the postoperative pain management for the thoracotomy, mastectomy, gastrectomy, cholecystectomy. But for the chronic pain conditions, it can be utilized for the post-mastectomy pain, post-thoracotomy pain, and also for the chronic pain conditions, including, as I told, in case of post-herpetic neuralgia or acute herpes zoster pain, and sometimes in case of scar neuralgia, in case of acne. So these are different indications for the this block, that means the intercostal nerve block. Now, contraindications, usually if the patient is having the disorder of coagulation and if there is a local infection, that comes into the contraindication. But number of contraindications is very limited from this block if you are doing it in perfect situation, as the nerves are very superficial. Usually there is no chance of any complication, but definitely if you are doing it very blindly and you are not putting it adequate care, then there is a possibility of the pneumothorax as well. So here we have to go into the lower part of the rib where actually there is a groove for the intercostal nerve. And at which location we are going to inject, we can do anywhere between the posterior and the mid-axillary line. That is the usual location for this nerve block. Now under ultrasound, now try to figure out the two ribs and the intercostal muscles. So once we are getting in between the two ribs, try to figure out the intercostal artery which can be seen in the lower part of the upper rib, and here you can use either the linear probe or you can use the curvilinear probe, but in most patients it is very superficial, so linear probe is useful in most of the patients. And from below upwards, go to that area. Be careful not to puncture the pleura, and once you are close to the vessel, then inject the local anesthetic steroid solution. Now, for chronic pain, long-standing pain, a radiofrequency ablation can also be performed. Also, the cryoablation can be performed here. And in some cases, we have found the advantage of the cryoablation is that it doesn't hamper the motor function of the nerve. So sometimes we have, though they are lacking in study, but in practical, we have seen the cryoablation working better in these areas than the ablation with the radiofrequency. Now coming to the high frequency linear transducer used for the scan at the thoracic region, and ultrasound involving provided the identification of the target. So we have to find all the structures, the most importantly the arterial pulsation and also the pleura. This to rib, arterial pulsation and the pleura. These three things you have to be sure in between. Whether you are able to find out all intercostal muscles or not, that is not very important, but the most important is you should not be going to the pleura. So once you are going there, then usually 1 to 2 ml of the local anesthetic steroid solution is injected. And in case of radio frequency, if you are doing want to do in pulse radio frequency, then go at 42 degrees Celsius for 120 seconds. And if you are going for the conventional radio frequency, then usually at 70 degrees Celsius, we can perform the conventional radio frequency for 90 seconds. So let us see the demonstration of these two procedures. Then we'll be moving to the next two procedures. Any questions? Okay, no question.
There is no sound, doctor.
No sound, sir. We have lost you.
Joint procedure and another. Huh? Oh. Hello, you can hear me?
Now, yes, sir.
Yeah,
Yes,
yeah.
can
Okay,
hear.
okay. So I was telling that the thoracic procedures are most of the procedures are for regional anesthesia. Mainly, it is done for regional anesthesia, but mainly only few procedures are there which are of importance in thoracic area for when we are talking about a chronic pain patient. So one of them is thoracic facet, and another one is your intercostal nerve. So here, so first for doing the thoracic facet block or thoracic facet median branch block. Before that, we want to know the structures. Where are the which structure is what? Okay, so in thoracic spine, most of the time we need the curvilinear probe. Though of course with the linear probe also we can see some of the structures, but if the patient is very thin, then we can see. But sometimes we need, most of the time we need the curvilinear probe. So let us see that how it looks with this. What?
Any queries?
Yeah, hello. Yeah, are you asking anything? Hello.
No, sir. Sorry.
Okay. So anyway, so this is the linear probe. Let us see that how we can see with the linear probe. Then I will actually show you with the curvilinear probe also. So here, first thing, think that this area is our thoracic spine. Okay, so just for an idea that which area is what. So we can palpate the scapular spine. Okay, so this root of the scapular spine, if we can palpate, so this root of the scapular spine actually corresponds directly to T3 spinous process. Okay, so this is the T3 spinous process, and tip of the T3 spinous process corresponds to T4 vertebral level. Okay, so this is the root of the scapular spine, and then comes the lower end of the scapular spine. It corresponds to the T7. Okay, T7. So this is just an rough estimation. Then we will see the spine by ultrasound in different areas. So if we talk about the sagittal sections, okay, sagittal views, then first we will see in the midline. So one is on the midline over the spinous processes, midline view. Then we will go just lateral to that. Just lateral to that, so that will be over the lamina. Okay, remember, if you can remember the bones, the structure of the bones, then these thoracic spines, the midline, they are very superficial. We can palpate also, we can palpate the bony structures over our with our finger, that these are very superficial. Then comes lamina. Here in thoracic area, lamina is the most deep structure. It is very deep. Okay, then again after lamina, third one is over the joint area. Okay, so how do we understand that which one is lamina and which one is joint area? So between lamina, between two bones, there will be some gap, but when it is the joint area, facet joint area, then there will be no gap will be very small. After that, we will see the transverse process, and then we will see the rib. So you understand how many sections we can see. Section 1 over the spinous process, section 2 over the lamina, section 3 over the facet joints, section 4 over the transverse process, section 5 over the ribs. So in that way, we will see all the areas in a sagittal section. Okay, so first let us see over the and what are the muscles actually in this area. So this area muscles are just again depth. Okay, and gain. Okay. So remember the midline view. It is a bit difficult. It is a bit difficult to see the midline portion. Okay, because the facets, because the spinous process, bony structure, it will show anisotropy because it is not a it is not a directly straight picture. I mean, the beams will not just reflect and will be received by the transducer. So this is the bony margin. So this is the spinous process. and this is also the spinous process. So this is a midline view. So let me decrease the depth and show you. Hmm, hmm. 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 This. Okay. So this is the midline view. So this much only we can see the periosteum of the spinous process. So here this part is skin. This part is subcutaneous tissue or fat. What is this white thing? This white thing? Anyone have any idea?
Ligament.
Supraspinous ligament. Supraspinous ligament. Okay. After that, of course, these are the interspinous ligament. Okay. These are the interspinous ligament. Now we will go with the second structure, that is over the lamina. But remember, this part is very deep. This part is very deep. So now we are on the spinous process. This is the midline structure. Okay. Now I am going over the lamina. This. Okay. You cannot see the depth here because that scale is actually hidden, but this is the lamina. This is the lamina. Okay, this part. So this lamina is not less than 2.5 centimeter. 2.5 centimeter. Okay. Okay, I'll make it yellow. 2.5 centimeters. So this part is lamina, we can see. So here there are these are muscular planes. These are muscle planes. Question comes, this is one muscle, this is one muscle, and these are another muscles. What are these muscles? Upper one, what is this muscle? At this area, one muscle is there. Can you say what muscle?
Trapezius.
Yes, trapezius. So at this, so this is trapezius. Now this point, another muscle is there. We can see the bones here above that. And this is not one muscle. This is a group of muscle. So what are these group of muscles? Erector spine. This is erector spiny group. Okay. This is erector spiny group. Okay. So after that, so midline spinous process, lamina. So this is lamina, quite deep. Now I am going a bit lateral. So actually this part hardly, this is not even, I mean, like only few millimeters. Okay. So here just understand the gap between two bones. Okay, fix code. Okay, just try to see the gap. Okay, I will show you with other probe also. Here actually there is no gap. Okay, so these are the facet joint line, articular process. This side is cranial side, this side is caudal side. Okay, so this is the superior, this is the inferior articular process. This is the superior articular process, and this part is the joint, facet joint. Okay, So how will you understand that whether it is joint or lamina? When this gap will be very small, then it is the joint area, and when there will be adequate gap, then you will say that this is a lamina. Okay, I will show you with the other probe. Okay. Oh, it is. So I will show you with the other probe. So here also, cranial side is in the left side. Okay, cranial side is in the left side. So here, just see the picture. So I'm showing you just. So midline we cannot see well. That is with the with your linear probe only. Whatever we can see, not more than that. After that, I am showing you the lamina. So this is the laminar area. This is the laminar area, and okay. So this is the okay. Here freeze. So remember, this is the laminar area. This is one lamina, this is another lamina. There is some gap. So this is the laminar area. As soon as I come a bit more laterally, then you will see this much gap is also not there. It will come like this. It will come like this. So that will be facet joint area. Okay, so this is the facet joint area. In the middle part, you see there is no gap. So this is the facet joint area. Okay, there is two bones. Two bones are more or less. I mean, it is forming a joint. There is no gap. Okay, just freeze here. This is facet joint. Here there is hardly any gap. This is facet joint. Okay. And when I am talking about lamina, then you see that there is some gap is there. So this part is lamina. Wait. Yes. Okay. So this part is lamina. I think you can perceive. Okay. Okay. So there is some gap. So this is the lamina. Now comes fourth picture. So fourth picture is the on transverse process. I have crossed the lamina, and now I will come over the transverse process. Okay. So here midline we cannot see. Then comes lamina. There is a gap. Then comes facet joint. So this one is the facet joint completely. Now I am coming in the transverse process. This is the transverse process. Remember, transverse process is much more superficial. Okay, transverse process is much more superficial. Now fix. You will understand it when I will make it transverse axis, then you will understand better. But still, so this is the transverse process line. Okay, so transverse process is always confused with that whether it is over the transverse process or over the rib. So remember, transverse process, this line is straight line, straight, and this is like the acoustic shadow you will see, but this part remains straight, and there is no pleura shadow. But as soon as we come over the rib, we see this one becoming completely rounded, and we see the shimmering effect of pleura. These two things makes the change from transverse process to coastal side, rib side. Okay, so try to understand, try to perceive the change of change of the superficial, the surface line from a straight line to round type of surface. Okay. So this one you see. So this much we have already seen. So this is facet. Okay. Yeah, facet joint. Now this is the straight line of the transverse process. This is straight line of transverse process because there is no pleura. As soon as I come laterally, I see the round structure. So this is the round structure of rib, and you can see the pleura below. That is the shimmering effect. This I mean trembling, or this is movement, vibration movement of the pleura is called shimmering effect. So this is the shimmering effect of pleura and round structure of the rib. Now I am going again medially. So I am going over the transverse process. Remember, transverse process is much superficial. Even it is high up than rib. Okay. Why it is higher up than rib? Try to understand by simply understanding the anatomy. A transverse process is posterior, whereas rib is anterior. Okay, so this is the most superficial. Okay, so these are transverse process, no shimmering effect, and upper part is more or less a straight line. So this is the transverse process. If I come a bit lateral, then I see the rib, which is a bit deeper and rounded. So I am on the rib, I am on the transverse process. Now we will go over the deep facet joint. I am on the facet joint. Upper one is on the facet joint, lower one is on the so this one, facet joint, just in the middle part over the yellow point. This is a facet joint. There is no gap over the lamina. Unfreeze. There is no gap in the lamina. So this is the facet joint. Now I am going in the a bit more medial. So that will be, so this part is lamina. Okay. This is lamina. A bit more gap is there. Okay. And midline structure we cannot see with this probe. That midline one I cannot show you, because then we need the this one linear probe actually. Okay, so this is the lamina and this is the facet joint. Okay, so these are the when we see by sagittal section long axis, then we see the structures like this. Okay, now I show you the transverse process. Transverse in the transverse section. Now we to the 11. So I will show you the transverse section. So in transverse views, there are two views. Either I can put the probe in between two laminas, or I can put over the lamina or in between lamina. So one is interlaminar view, one is over the lamina view. Okay, so if I go over the lamina, then I can see the lamina and the root of the base of the spinous process, not the whole spinous process. Okay, and I will see the up to transverse process. Okay, but then if I so let me see first. So then you will understand that what I showed you in longitudinal view. So here, so here you can see this is the structure. I have shown. Okay, just freeze. So here, so here you can see. So this is a laminar view. This is a laminar view. Here it is the transverse process. This is the lamina. This is the lamina, and this part is the transverse process. Okay, so this part, what is this part? This part, anybody will say that this is spinous process. Of course, Yeah, of course it is spinous process, but it is only the root of spinous process, root or base of the spinous process. Okay, this is the spinous process base only. Okay, base of the spinous process. Camera off কি হবে? Just a minute. ওইটা ও আচ্ছা ঠিক আছে so okay so this is the base of the spinous process and you have seen this is the lamina so in this view you can understand that lamina is so deep even the facet joint is here so that is also so deep and when we see the transverse process it is the most superior most structure okay even when you see the rib is also much superficial but not as superficial as the transverse process. So rib is here. This is the rib and this is the transverse process. Okay, this part is rib. This is the transverse process. So you can understand that what I was showing you in the longitudinal section. So remember this is the only starting point of the transverse process. Okay, why I am saying this? I just show you. Okay. Another thing now, these muscles, these are erector spiny muscles. This is the trapezius. This is the trapezius. These are erector spiny muscles. Okay. Now I show you another view in the midline. So that will be interlaminar view. So laminar view or interlaminar view we can see just by the bone, just by the lamina and transverse process whether we can see continuously or not. When we will see interlaminar, we should be able to see some part of the anterior complex also. So this part is the interlaminar view, though we cannot see the So we here we cannot see, but still sometimes it is possible to see the anterior complex also. When you are not seeing, the bony line, bony straight line, bony straight lamina and transverse process, then you are in the interlaminar view. Okay, so this is the interlaminar view. So here one important thing is, freeze kar. So here of course we cannot see, but sometimes in a thin patient we may be able to see the anterior complex here. Okay, and here a posterior complex. Sometimes posterior complex is not seen, but anterior complex is seen. And here, since we are not seeing a straight line like this, we are not seeing, so it is a interlaminar view. Remember, here we see a spinous process, and this spinous process corresponds to the upper vertebra. Earlier also actually the spinous process, when we are seeing the root of the spinous process of the same vertebra, or the shadow represents the tip of the upper vertebra, not the same vertebra. Okay, so here 100% it is the tip of the upper vertebra. So say it is T3, we are seeing the spinous process of T2 and not T3. Okay, so this is the difference. Second thing, now we will focus on this part. We will focus on this part. Okay. Okay. So this is the interlaminar view. when we are not seeing the lamina and the that is continuous with the transverse process, but we can come to the laminar view also. So this is the laminar view when we are seeing only the root of the transverse process or the tip of the upper spinous process. Okay, now I am going to one side, okay. Now let us focus on these areas. So what we are seeing here in decreased depth a bit, কমার ওই উল্টো দিকে যা হয়তো okay. So this is the once as I have come to one side, so I am seeing what I am seeing, the transverse process here. But then okay, freeze. Okay, so we can see that transverse process ends here. Transverse process ends here. This is the transverse process, and this is the lamina. Okay, this part is spinous process, we understand. So here now what we are seeing, so up to bone we can see. And what is this structure? Anyone can say what is this structure?
It's the rib.
Pleura. Rib is at the level of the transverse process at this area. It is not that difference is there. Okay, this much difference is not there, because here we can see the bony margin ends here, then rib has to be here. It cannot be so deep. So just see, and whenever you will see a rib like thing, it is a bone, so below it will be everything black, acoustic shadow has to be there. So here we can see the transverse process. I am bringing it in the middle part. Now I show you the rib. So this upper part, upper one is rib, okay, which we cannot see the pleura there, and you can see it is at the similar depth. When we see the pleura, now it is the shimmering effect of pleura, which is much below. Rib is above, so this one is rib. Now we are seeing the rib and transverse process. Now we are seeing the pleura and transverse process. Okay, pleura and transverse process, rib and transverse process. Some part of pleura also comes, but then this is the rib and transverse process. Now when I am seeing this, okay, please go. Okay. So when we understood that this is pleura, this part is transverse process, this part is lamina, of course. So
and where is the facet joint, Dr.
what
facet joint in this view?
Yeah, facet joint, I'm telling you here. Here I will show you the medial branch locations. Facet joint already we have seen in the longitudinal views. Okay, but then here procedures we mostly do the medial branch procedures, not the inside the joint. It is not much easy to go, or not even we do that procedure. Okay, in this view, so what is this thing? Anyone can say what is this thing? These tissues.
Intercostal muscle.
Yes, these are intercostal muscles, because we have seen rib comes here. Okay, so when we are not seeing the rib, so say rib is here and I am seeing just below, that means in between the ribs. So at this depth, these are all intercostal muscles. Okay, so as soon as I have seen these structures, so this is the transverse process. So here I will see the uppermost angle of the transverse process for this procedure of median branch. So as I told you, T4 to T9, most of the time it is a bit difficult because it is not at the upper and outer level, but above T4 it is all at the upper and outer level. So here, if I can see, so this one, so here I can see that I transverse process and rib both. Okay, here I can see there is no rib, it is the pleura, and here again the rib and transverse process. So if I go just above like this, so in this point I can see that there is no transverse process. So at this point when rib is there, my needle can come from one side and I can actually here PDI দিত ছোট করে কি করে রেকর্ড দিবি না চলে কালার দেবো এটা ছোট করে কি করে স্মল wait, so I'm trying to see that if there is a, so this is the rib and transverse process. So just at the tip of the transverse process sometimes we can see a vessel also. So that is the associated vessel with the median branch, but if we don't find also, when I have put the probe like this, that rib is there in one side and transverse process I can see. So when my target is at the upper and outer level of the transverse process, my needle can come like this and I can hit this area, and then you can I mean do the block also, and you can stimulate and do the RF also. So this procedure can be done in this view also and in the opposite view also. Okay, opposite or longitudinal view. So how longitudinal view you can do it? So by, so here already you have seen, so this is the transverse processes. So these are all transverse processes. So if you have any confusion, you can at least go in laterally and see that okay, these are the ribs. So this is the transverse process. So here, so I mean like you know the depth of the transverse process. So at this depth only, in between the, either in between the transverse process or in the upper and outer margin of the transverse process, you can put your needle. So these areas sometimes we see a vessel and sometimes we don't see. So here you see one vessel here. Okay, though it is not at the exactly correct position. Okay, so this may not be the vessel, but okay, freeze. Okay, so in this view also, for doing a block, our needle will come to this level or to this level. Okay, upper and outer quadrant of the transverse process. And if it is within the T4 T9, then we have to hit first and then we have to redirect the needle up to this much. That's it. At the same plane between these two transverse process, there we will give a local anesthetic block for the median branches. Okay, sometimes we see a vessel in this area which is which will be associated with the medial branches. Okay, so this is for medial branch block. And I told you that if I mean you can see this structure for the facet joint injection. So this is the facet joint. Okay, so this is the facet joint view. So this is the facet joint view when there is hardly any gap. So this is the facet joint view, but then this with ultrasound and in this view putting a needle is a bit tough or risky, you can say. Okay, so this is the facet joint view. So this is laminar view and this is the facet joint view. Okay, this is the facet joint view and this is laminar view. This is the facet joint view. Okay. So I think you have understood, isn't it? Any question here in this? I mean, what I have showed you is facet joint procedures. Either you can see the inside the joint or in the medial branch blocks. So any question here, or I will just show you the this one, intercostal nerve block. Intercostal টা তো বলতে হবে না? Okay, okay. So intercostal nerve block is quite easy. So it is mostly done for post-herpetic neuralgia. Post-herpetic neuralgia. So we will come as per the requirement. We will first count that which rib is what. So there are multiple counting procedures. So here, as I told you, that we can count in this way also, that T3 and T9. So this one also gives us the level, the idea about the leveling. Okay, about the level. And otherwise you can go up. So from here also you can know that which one is what rib. So this is the T2 rib. Okay, after that you can go on counting and you can understand that which one is what. Okay, so here, say in this area I am seeing. So remember, what is the location of the intercostal nerve? It is the lower margin of the upper rib, lower margin of the upper rib. So PDI, if I give here, we can actually directly see the vessel, but it is not taking the color somehow. So remember here, one more important thing is, no. So actually we can see. Okay, sometimes it is taking, yeah. Okay, so sometimes it is showing, but it is not taking that color. But this is the upper rib, this is the upper rib, this is the lower rib, and here remember the first structure what we get is nerve. Second structure is vessel, artery or vein. Okay, second structure is vessel. So it is good for us when we put an injection like this. First what we encounter is nerve. We do not have to puncture vessel. So just in this way we can do the stimulation, RF, normal block, everything. So just you are, so this is very much easy procedure, because as soon as we see the rib, we know this much is the intercostal muscles. This plane is the intercostal muscle. It starts from here and pleura is here, so up to pleura. So this much is the intercostal muscle. So you know what is the location. Location is always between the internal intercostal and transversus thoracic, innermost intercostal. Internal intercostal and innermost intercostal. So this is the location, lower end of the bone, I mean rib. So this is the nerve actually. This is the nerve. So just try to see again.
Sir, where's the pleura again?
Pleura. See? PDI বন্ধ করে দে. Okay. See? Wherever you get a shimmering effect, that is the pleura. Some vibration is there, no? Some vibration is there. So that is the shimmering effect of pleura. Wherever you see pleura, that is the shimmering effect. So this is the shimmering effect. So this is the pleura. You can see, no? Any confusion here?
So the intercostal nerve is very near the pleura.
Of course, it is near the pleura, and that's why it is the one of the commonest complication also for intercostal nerve. Earlier, people used to do blindly, so that chance was much more. But now you can do the procedure with inline technique. So you will see the whole needle. You will see the whole needle coming gradually. So you have to have the control of the needle's tip. Okay. So here I can see the actually nerve also, but it doesn't take color. But we can see the nerve also. Okay, you can see. Color দিলে আসবে না। Oh, so see the vessels. It is taking the color. One red and one blue, but then yeah, it is taking the vessel color. So in that area only, nerve is there. Sometimes we see that.
Sensitivity come out color.
No, বেশি করা আছে। Okay, so this is the area. We can see the artery and nerve also by the side of the artery. But then here, of course, it is a chance of doing pneumothorax. So you have to be very careful. But it is the lower border of the upper rib. Okay. So I think this much is clear. No, anyone have any confusion? Then please tell me.
Hello.
Sir, can you show us about the facet joint injection
Hello?
again? Maybe.
Facet joint injection again. Just a minute. Okay, so I actually see, as I told you, that facet joint you can see in the with ultrasound, but going inside the facet joint in a thoracic spine is not done usually due to its chance of complications. If you go a bit medial, you will directly go as a interlaminar. I mean, your needle position will be interlaminar. Okay, because it is just by the side of the just medial to the facet joint, the needle can go to interlaminar position. So I think we have to see by that probe only. Just a minute, let me check. No, we have to see by that probe only. Okay, so gain, increase the gain. So this is the facet joint. Okay, so why this is the facet joint? You see, this is the lamina, but so here you have to understand that both lamina you have to be able to understand where the upper lamina ends, where the upper lamina ends and where the lower lamina starts. Okay, and then see the gap. As soon as you see the facet joint area, there is hardly any gap, very small. But if it is I mean lamina area, interlaminar area, then gap will be a bit more. So you just see where the bone one ends and one starts up. So upper lamina and lower lamina, these two bones you have to be seeing clearly. So this is the rib part. This is transverse process. This is the lamina actually. This is the lamina picture, but I have to show you the facets. So this is the facets. This is the facet. See, there is hardly any area of, so this is the facet area. Okay, there is hardly any gap between two bones. When there is adequate gap, then that is the so this is the lamina. This is the lamina when there is adequate gap, and this is the facet joint when there is no gap. So this much, so this much when there is no gap, but this much a bit of gap is there. So this is actually a continuous bone. Here when we are seeing, so you see, so this is the transverse view. Just So this is a transverse view. Here lamina is only this part and facet joint is this part. So suddenly your needle can come in this area also and you will be inside the spinal canal. So here in this view, going inside the joint is not a very good idea. That's why we always try to go do a median branch block here. Okay, this area is for median branch. So as soon as you see the transverse process either in this view or longitudinal view, you can see the upper and outer part of the transverse process. That is much easier. Okay.
Okay, thank you.
Okay, so let us continue with the paravertebral block. So paravertebral block is again one of the older blocks. Again, as you are telling that the procedure is risky, it is same here. This procedure also have some risk because you are going very close to the pleura and even closer here at this point. So where is the paravertebral is actually paravertebral block? It is the injection of the local anesthetic alongside the thoracic vertebral body near the intravertebral foramen. So it is actually blocking the nerves that is coming out from the spinal cord. So it produces an unilateral, segmental, somatic and sympathetic nerve block because both the grammar communicants are there and multiple contagious thoracic segments as the drug is moving up and down. And if you give too much volume, then it can go further up and down also. Okay. Now coming to the history. This is a quite old block and first invented by the Hugo Schillam, and then it is used later and the use increased gradually. Now what are the boundaries of this thoracic paravertebral space? So it's a wedge shaped space between the vertebral body and it is bounded by anteriorly by the parietal pleura, obviously anteriorly there will be the parietal pleura. Posteriorly it is bounded by the costotransverse ligament, mainly the superior costotransverse ligament, and base or the wedge is found by the posterolateral surface of the vertebral body, this side, and the intravertebral foramen. So along with the nerve. So whenever we are giving the drug, this area is whole taking the drug. And there are two fascia as contained. They are the endothoracic fascia and subserous fascia. And also the important contents are the intercostal nerve, intercostal vessels, dorsal rami, sympathetic chain, and a little bit of fatty tissue. So if you look at this point, you can see the endothoracic fascia. Here you can see the subserous fascia. These are the visceral and parietal pleura. And this is a very important structure. This is the superior costotransverse ligament. So here it is going from the rib to the transverse process. So it is moving like this. And there lies the lateral costotransverse ligament. And at this portion, we have the intratransverse ligaments. Okay. So here, while doing the block or performing the block, we have to just cross the superior costotransverse ligament. And at this point, we have to inject the drug. So the area medially communicates with the epidural space, laterally communicates with the intercostal space. Contralaterally, it connects with the contralateral paravertebral space via both paravertebral and epidural roots. Inferiorly, it extends to the retroperitoneal space and cranial extension is not clearly defined, but it is continuous with the cervical paravertebral region and post-thoracic paravertebral region. Now coming to the mechanism for the block. This actually, the thoracic paravertebral block results in an ipsilateral somatic and sympathetic nerve block both, because here the Ramayana communicants are also going and also the nerve roots are coming. And sometimes it can extend to the intercostal space laterally and also to the space medially and enhances the block if more volume is given. Ipsilateral spreads towards the epidural space contributes to the dermatomal anesthesia, Predictability of the dermatome distribution following a injection varies, and it varies according to the position of the needle, the area and amount of the drug provided. Multiple injection techniques preferred for a reliable anesthesia, and approximately 10% of the patient may experience segmental contralateral anesthesia as it is continuous with the opposite side. So a small number of patients, if it goes to the opposite side, they can also distribute a contralateral anesthesia. Ultrasound grand scan may be performed in the transverse or longitudinal axis, and the procedure technique can also be done in transverse and longitudinal axis. Both the techniques has been demonstrated in different studies. Remember, this is a block when initially started, it started as blind, then along with the fluoroscopy and then along with the ultrasound. But the most safe is definitely the ultrasound, because here we can see the needle tip and at the area where we are injecting. A patient positioning, the preferred position is either supine or the patient, either prone or lateral decubitus, or sometimes sitting. In chronic pain procedures, the sitting position can also be adapted. Now, here comes the structure. Here I have already shown, but you would have shown in the anatomical 3D also. This is the intertransverse ligament. This is the superior costotransverse ligament. This is the lateral costotransverse ligament. And anteriorly, it is not shown here. There lies the pleura. So this is the space after crossing the superior costotransverse ligament. We have to inject the drug. So it is this position. So it will be covering all three nerves. Now coming to the anatomy of this region. So if you look at in a transverse view, so what we can see the lung here. Here it is the apex of the thoracic paravertebral space. Here we have the superior costotransverse ligament which lying posteriorly, and here we have the posterior intercostal space which is continuous with the thoracic paravertebral space, and in this side it is continuous towards the spinal cord. Okay, and here anteriorly remaining the lung. So what is first most important, that we should not be crossing this line. We should be anterior to the superior costotransverse ligament but posterior to this lung, and this is very important while doing this block. Now coming to the question that whether blocking under this situation and seeing the whole nerve is easy or blocking in this situation is easy. Remember, while we are blocking in a longitudinal view, the problem comes is that here putting the needle sometimes becomes difficult because you have to negotiate in between two transverse processes. So sometimes we have to take a route which is not a inline view. Sometimes you have to go in an out of plane view, and while doing out of plane view it becomes more riskier. So it is better to give in a horizontal plane, but you have to be careful not to puncture the lung. In that case, it is comparatively easier to put the needle in inline view. Now, this is the paramedial sagittal sonogram of the thoracic paravertebral region. So, in that case, you can see this shiny lung. Here lies the transverse process. Here, one thing is very important to be able to identify the transverse process and the rib. Remember, the transverse process is usually a little bit squarish shape, whereas the rib remains a little bit roundish shape. And also, while transitioning from the transverse process to the rib, usually transverse process is a little bit superficial, whereas the rib in comparison with the transverse process remains a little bit deeper. So we have to first identify the two transverse processes, then we have to identify the superior costotransverse ligament and the lung, and in between this area we can put the needle. Remember, all types of studies are available. It is not that I have told it is difficult, the studies are not done here. Also here putting the needle like this was there and it is studied, but sometimes it becomes a little bit difficult because as you have to go in a steep angle, so needle visualization suffers here sometimes. Okay, so it could be difficult. It appears very simple, but sometimes it could be difficult. Now coming to the basic consideration of the ultrasound guided thoracic vertebral. First of all, transducer. Which transducer we will be taking? In most of the cases, sometimes we have to take a low frequency probe. If the patient is very lean and thin, we can take a high frequency probe as well. And usually the scanning depth is 4 to 6 centimeter in most of the patients. So in some patients, actually the low frequency probes proves beneficial. Now, needle in which ways can be placed? First of all, as I shown, it is the transverse scan with the short axis needle visualization. Here we are putting the needle with the, it can be possible with in plane and out of plane, but here usually this in plane technique is comparatively safer compared to the out of plane, and this second and third position is comparatively in plane technique, and you can adapt in between to out of plane. Usually we do not recommend for your procedures. Now, to do in a short axis needle insertion, you have to first locate the transverse process and the rib, and then go into the intertransverse area. Remember, this picture we will be able to see in the intertransverse area, and after seeing this, you put the needle slightly anterior and into the thoracic paravertebral space, inject the local anesthetic and steroid. Okay, and paramedian sagittal oblique scan in plane needle insertion is also possible, and if you are taking at multiple level, you want to cover for multiple refractures, in that case you have to put the probe at multiple location. That actually improves the your distribution of the drugs. Remember, giving too much drug at a place might give rise to a wrong spread of the drug. Okay, now coming to the conclusion, ultrasound definitely it is precise real-time imaging of the thoracic paravertebral space. It is safe, non-invasive alternative. Improved technical outcome is definitely having with the ultrasound and reduced complication, but there are challenges like selecting the axis and proper needle visualization. And the similar block nowadays, you have already seen, this is a comparatively riskier block. So nowadays, in most of the post-operative analgesia cases, now it is replaced by the erector spinae plane block. Remember, it is a very simple block. It is hypothecated that the nerves which are coming from the thoracic paravertebral area, they are going through the in a small branches to the erector spinae plane as well. So erector spinae plane was first described in Ferraro et al. In 2016, and for the thoracic neuropathic pain, it has shown that the rapid adaptation and efficacy, and in different pathological conditions it has been used, and it was initially dubbed as the poor man's epidural, and it targets space to the deep to the erector spinae muscle. So in between the transverse process and erector spinae muscle, in that plane the drug is injected. So this is the initial study and the case study that has been published at the when the invention of the erector spinae plane block. Initially, it has been used for the neuropathic chest wall pain, breast surgery, and the rib fractures, particularly effective for the posterior rib fractures, often resistant to other intrathoracic analgesic approaches like the serratus anterior plane block, and demonstrated efficacy in the lumbar and the sacral levels, and also for the abdominal and pelvic pain. And it has potential to block the sympathetic fibers, offering relief from the visceral pain associated with the thoracoabdominal pathologies as well. Effective in conditions like the renal colic, pancreatitis, and appendicitis as well. But remember, as here while doing the erector spinae block, it is a one-time block. That means we are injecting either dopivacaine or bupivacaine for a longer duration, but its use actually in chronic pain is now limited nowadays. While the exact mechanism is not fully understood, studies suggest that the local anesthetic spreads through the interfascial plane towards the posterior rami of the spinal nerves, and some anterior diffusion to the paravertebral space may also contribute to the efficacy of this block. So here we have to go at the junction of the rib and transverse process, and I already told the rib will be looking a little bit squarish, so you have to go slightly lateral and medial, and then we have to find out the target which is deep to the erector spinae muscle and above the transverse process, and at this point put the needle over the rib and inject 1 to 3 ml of local anesthetic and confirm the drug sprayed just deep to this erector spinae muscle, and complete the nerve block with 20 to 30 ml of the local anesthetic. Okay, and once this is the picture, and here we have to put the needle deep to the trapezius, rhomboid, and crossing the erector spinae muscle. And probe position, usually the probe position we already know it is actually the longitudinal probe position, and so that rib can be seen as a transverse section, and it is a flat squared hypoechoic line and with the acoustic shadow behind, and pleura should be should not be visualized at the block level. While we are injecting at this point, we will be able to pleura above and below, but at the block level, the pleura should not be there. Okay, now if it is too medial, you might see the lamina. If it is too lateral, you might see the rib. So you have to come in between. That is very important to identify the squarish transverse process. So once it has been done, then you take the needle out. Complications is much less, but infection, hematoma formation, that could be there. So for which you have to take the adequate precautions. Now Dr. Roy will be demonstrating these two procedures.
No, So first I show you the erector spiny block. Okay, then I will show you the paravertebral block or paravertebral block. So for erector spiny, let us see the muscles again. Okay, so here see already if I put in this way, so I'm holding I'm using this probe. This one is your linear probe, so I'm using this probe. So you can see that this is the transverse process area and this is the lamina area. Lamina much deeper, bone is at much deeper level. So we can see that these in between this area, just hold it. So between the transverse process, so annotate. So this is the transverse lamina, this is the lamina. So above this lamina, this part is all muscles. This part is all muscles. Now let us try to understand that which muscle is what. Okay, this we have understood that this was trapezius. So this part is your other erector spiny muscles. Okay, so just under the trapezius, it is the erector spiny muscles. Though it is, if you go up, then it is not only the trapezius, rhomboids will come. If you go more up, then there is a small muscle that is serratus posterior superior. So let us first check that whether we can see the rhomboids or not. So rhomboids, it is much easy, very easy to see that rhomboids. So if I hold here in the lower part of the scapula, I can see two levels, two layers. So one is trapezius, one is erector spiny. As I go up, I can see another layer in between. Okay, another layer in between, which is actually just getting finished, getting over. At this area, it is over. Okay, if we go up, then I see that this layer is bigger. Okay, so what is this layer? So this is the rhomboids. This is the rhomboid, second layer. Just freeze. So this is the rhomboids. So this is trapezius, this is rhomboids. Okay, rhomboids actually that is over by like this at C5, C6 level, not C, T. T5, 6 level, it is, we see that it is like, it is vanishing. Okay, so this is rhomboids and this is the erector spiny. Okay. If you want to see the erector spiny now, specifically which muscle is what, then see. Okay, so I'm going up. So I can see that three layers. One is trapezius, rhomboids, and erector spiny. Now here I am going for rotation movement so that I can show you. So you can see this trapezius and rhomboids, you can see, and I am going medially in the thoracic area. I am going medially. So here, okay, so I think now you can see. So freeze. So already when I did I did the rotation, you understood that this is from trapezius, This is rhomboid. This one is transverse process of thoracic vertebra. This one is spinous process. Okay. This is pleura area. This is pleura. Here has to be the rib. Okay. So we are talking about the erector spinae. Erector spinae has 3 muscles. Okay. So this area, if you see carefully, you will see it is a different muscle belly. So this is multifidus. This part is spinalis. Spinalis. Now we cannot separate spinalis cervicis, spinalis thoracic, spinalis occipitalis. So these things we cannot separate, but this is spinalis area, and this side is longissimus. Longissimus. So these 3 muscles together we call them as erector spinae. So what is our target? We want to inject some fluid here in local anesthetic here in this area, just over the transverse process, so that it is a plane block. So within this plane, the drug will spread. Of course, it travels to the roots in some way, but still. So this is our location of injection. Okay. So we have understood which muscle is what. So here you can see again where is the multifidus. Deepest muscle is multifidus, above that spinalis, and if we go in this way, so here we can see some part of longissimus also. And now I'm not going in laterally, otherwise we can see other muscles also. So anyway, so here on the transverse process in the middle part. So 3 types of injection can be done. Okay, just freeze here. So in this view, so one can inject in this view also. Okay, just put like this, your needle will come from this side to this side and just redirect here a bit in the okay, no, it is better to just I was showing erector spinae block, so it is better. Erector spinae block is in the sagittal section. I was mixing up with paravertebral. Sorry. So this one is the erector spinae. Okay, I will hold the probe like this. Okay, I will hold the probe like this. So just please. No. Okay, yeah. Okay, so I will hold the probe like this. So this is above the transverse process. So this is one transverse process and this is another transverse process. This side is cranial, this side is caudal. Okay, our needle will come from this side to this side. So first I will hit the bone and then I will just redirect a bit below, so that the fluid separates the whole plane. The whole plane will be separated from the below structures. Okay, so that is the erector spinae block. Okay, we will show you the video how erector spinae block fluid spreads. Okay, so our injection it will touch the lower border of the upper vertebra. So this is our target. Remember, many times we have seen that fluid splits the lower fibers of the lower erector spinae muscles. Okay, lower fibers. So always see that you are out of the erector spinae muscles. If you are really out, then you will see that it is just splitting the whole plane like this. Then it will not press the lower fibers like this. Okay, this is wrong. So it should go below this plane, below the erector spinae plane. So this is for erector spinae block. Okay. Now
So, sir, what's the structure between the 2 transverse process?
It is actually loose areolar tissue. In this area, it is the loose areolar tissue. Of course, it is the paravertebral area also. It is the paravertebral block area also. This is a paravertebral space also, but some loose areolar tissue is there. At present, if you go below also, you are not going to hit go inside the pleura. It is not inside the pleura. Okay.
Yes, sir.
Okay. Last procedure. So this is the okay. So now it is the paravertebral block. So just see that where is the paravertebral block. So remember here paravertebral block, here the main important structure is only one structure, that is the superior costotransverse ligament. Remember transverse process is here, I mean it is the posterior structure, transverse process is posterior structure, rib is anterior, okay, and from upper part superior costotransverse ligament is attaches to the transverse process. Superiorly it attaches to the transverse process, and caudally it attaches to the rib. So it is the from transverse process to costal cartilage. So it is the costotransverse ligament. So this is the your superior costotransverse ligament. This is actually better seen, always better seen in the curvilinear probe. So I show you in the curvilinear probe. So here I show you that this is the, so this is the rib shadow, all the rib shadow. We can see the pleura, we can see the shimmering effect. I am going over the transverse process. I am going over the, so this is the transverse process where I cannot see the pleura, and this is the transverse process. I mean, like it is square type of cross section. Okay. So now from this area, when I am seeing the transverse process from this area, if I see a bit laterally, then I will see the pleura. Okay. If I see medially, then of course I will not see the pleura. I will see the facet joint and all this side. So this is the facet joint area. So I'm on the transverse process at this point. Okay. So what I will do here, in just under below the yellow mark, this is one transverse process. I will just make the lower end to go a bit lateral, a bit lateral. So this is a view where so this is a transverse process, all are transverse process. So this is a view where upper, no, don't freeze. So upper one is transverse process and lower one is in the costal cartilage. Otherwise we can do this one also. In him actually it is more of a okay. So I remain on the transverse process only. I remain on the transverse process and I am just seeing a bit laterally, a bit laterally. So here, so this one, okay, should yeah, please. Okay, so what I am seeing here, what I am seeing here, you can see clearly. So this is a bit, I am not straight, I am just a bit oblique. My ultrasound probe was a bit oblique. So this is the view of transverse process, and this is the rib, coastal I mean cartilage. This is the costal cartilage rib view, and this is also rib cross section. Okay, so here we can see two structure. Pleura we can always see. Pleura, as soon as rib is seen, pleura is also seen. So this is pleura. Another structure which is most important, that is costotransverse ligament. It will come like this, superior costotransverse ligament. Try to see this structure. Between these two structure, always you will see this type of structure. I show you again. Just try to understand this. Okay, so this is the transverse process area. Okay, this is the transverse process area. From here I see like this. Okay, I see like this. So this is a superior costotransverse ligament and pleura, both we can see. Okay, so this is the picture. Both we can see. I can see it in another level also. So anywhere we can see this type of structure. Okay, we can see below also this two lines. You can see these two lines. You can see these two lines. If I go up or below, I can see these two lines. I can see these two lines. All of you can perceive these two lines. Upper one is in the transverse process, lower is in the lower end is in the costal side. Okay. So these two lines, above line is nothing but the costotransverse ligament. Okay, nothing but the costotransverse ligament. Freeze করতে? Okay. So this one is the costotransverse ligament. This one is superior costotransverse ligament. Lower one is pleura. Lower one is pleura. So where our needle will come? Needle will come from below to this place. Okay. So this area is actually the paravertebral space. This is the paravertebral space. This area is also another space, the upper area. So this is called RS space. RS. This is retro costotransverse ligament space. So sometimes, sometimes, this is very close to the pleura. So someone, if a bit afraid of going here, someone may inject here also. So both the spaces have connection. Fluid can come from this place to this place. So RS space and paravertebral space are connected. Okay, so someone can inject here also and fluid will come here. Okay, so that is also possible. But needle, if you want to do correctly in the paravertebral space, your needle must come here. So you have to see both these two lines. One upper one is costotransverse ligament, lower one is pleura. Okay. So any confusion here? And as far as counting is concerned, that which level is what. So remember, we can go gradually up and we can see that this. So we can see that these ribs, no, we can count like this, we can go up, 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 up. So at this level, okay, the area where it ends, so that is the T2 level. Okay, so this one is the rib. You can see the ribs. I'm going up. After going here, there is no more going, I cannot go more to see a cross section. So this is the first one, is the second rib, that is the third rib, this is the fourth rib. In the middle part, this is the fourth rib, this is the fifth rib, this is the sixth rib. So whenever you do any procedure in the thoracic spine, so if you want to go for a you need to know the level. Okay, so this is how we count the level. Okay, any question here? Okay, I think it's done.
Okay, let's go for the MCQs. Hello, am I audible?
You are, sir.
Okay, fine. So please join.
Love Street, Chitty, P.S.
That
Vincent,
boy.
Captain Queen, Lucky Street, Lucky Lovely Fire. Ice, Slow King, Quick Pig, House King, Slow Heat, Slow Heat, Ack, Jolly Woman, KS, Fluffy Lion, Quiz.com, play and create.
What is the arrow-marked hyperechic structure? Here ESM equals erector spinae muscle. Pleura. Which procedure is being done?
Papa Hacker 1 joined.
Paravertebral block. Erector spinae block is being performed. Which structure is star marked here? Intercostal muscle. At thoracic spine level, it is A. Thoracic spine level, it is A. At 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 thoracic spine level Long axis view over the lamina. At thoracic spine level, this is a Long axis view over the transverse process. Paraspinal long axis view is seen over the transverse processes for performing paravertebral block, which is the PVF. Two. Which is false about intercostal nerve. Used as a treatment in respiratory decompensated patients. Which of the following anatomical structures is targeted for hydrodissection in the modified 5-in-1 technique? Dorsal scapular nerve and spinal accessory nerve. In periscapular and mid-thoracic myofascial pain, a 5-in-1 TPI and hydrodissection technique is tried, which is rhomboids and serratus posterior.
Final question. Double points.
During thoracic spine scanning by USG, which is the deepest structure among the below given choices? Lamina.
Third place. Love Street. Second place. Jolly Woman. And the winner is Lucky Street.
So, who is Lucky Street?
So, Dr. Vanita.
Okay, congratulations. Chimara, you want to show? Okay, just wait. Dr. Roy will be showing one procedure video recording.
Yeah. তুমি অডিওটা বন্ধ করো। So just I show you this Okay.
Hello, Sifa.
Okay. So this was a erector spine plane block. So this video, so you see the lower side, you can see the transverse process. Left side, medial side, right side is caudal side. I cannot see the needle. It was a bit stiff. So I'm giving some fluid in between to see that at what plane my needle tip is. So gradually it has entered in the correct plane. Now, when I'm injecting the local anesthetic, then you see that how it splits the erector spiny whole muscle group. So now you see the splitting. So this is the whole splitting of the erector spiny group, and lower part it is the transverse processes actually not clearly seen here. Recording is not very good. So anyway, so you see the splitting. So it is very nicely split. So this is very nicely split here. And when I started, it was just, this is the transverse process. I'm not seeing the needle where it came, but so I did some local anesthetic in between I gave, and I saw how much plane it came. And I saw the, and when it came to the right place, I injected. So now you see that how it splits. Okay. So this is the splitting we want, this type of splitting. Okay, if it is in the right plane. Okay.
Si ce programme est intéressant, on peut aller pour ça. Mais quand
Okay,
good
night.
Ça paraît intéressant. Ils peuvent